Hi everyone, let's talk about the HPA Axis, and that stands for hypothalamic pituitary adrenal. So this is an axis system in the endocrine system as a whole that is generally thought of as the stress pathway, but when we talk about stress, I want you to think of physiologic stress, not necessarily so much psychological stress. So looking at the hypothalamic pituitary adrenal system. So that's what the A stands for, the adrenal glands. We generally have two adrenal glands and they sit atop the kidneys, which gives them another name, which is the suprarenal glands. So they lie atop the kidneys. They are not technically a part of the kidneys. They are two distinct organs that sit on top of them instead. There are some heavily vascularized glands that let you know that there's a lot of hormones coming to them and then going away from them. So we've got these suprarenal arteries associated with them and suprarenal veins so that we can have hormones travel from the brain to signal to cells in the adrenals, and the adrenals can respond by making their own hormones, which can then exit through the venous system. There are two adrenal glands. We have a right one and a left one. And even though there's two, within each one of the adrenal glands, there's technically two distinct organs. Each part of the adrenal gland, the cortex and the medulla or medulla, say it however you would choose, is its own distinct organ. The cortex is associated with its own products, and then the medulla or medulla is associated with its own. So even though they are encased inside of one adrenal gland each, once we cut it open and see the different levels, we can see that there's two distinct glands. It then gets even more complicated because the cortex has many layers associated with it. But generally, think of the adrenal cortex and the adrenal medulla as two distinct organs. Inside of the cortex, and cortex is Latin for bark, in the same way the bark of a tree covers it, that's the way a cortex is with an organ. So like in this picture, the C is for cortex and then the M is for medulla. So this is an adrenal gland within its little capsule, and this cortex region is histologically different from the medulla region. This V there, that's for vessel. That lets you know that these products, as they're created, can travel right through the bloodstream. A schematic of this is right here. So we have these three distinct layers of the cortex, the glomerulosa, fasciculata, and reticularis layers. And these layers each have their own specific products, which then are distinct from the medullary layers. The layers of the medulla itself make their own products, which are not steroid hormones like the products coming from the cortex. Instead, we see catecholamine production by the cells in the medulla. So the cortex has these three zones, glomerulosa, fasciculata, reticularis, and they're all associated with their own product, generally steroid hormone related, and then the medulla is associated with catecholamine production. When we look at the cells of the medulla, they are part of an interesting deviation from normal physiology in the sympathetic nervous system. So if you remember, the sympathetic, your fight or flight, involves typically a two neuron chain pathway. The place where they meet up, remember, is called the ganglion. So we have a preganglionic and a postganglionic neuron. And the preganglionic neuron releases acetylcholine, which would bind to nicotinic type receptors on, don't tell my pharmacology professors I ever messed that up. I was talking too fast. All right, sorry. All right, I'm done crying for a second right now. So the acetylcholine would bind to, I did it again, the nicotinic type receptors on the postganglionic cell, which in the sympathetic system would release norepinephrine in response to that. So that is what the typical SNS chain looks like. There's one place in the body associated with the sympathetic nervous system that does not have a 2-neuron chain pathway, and that is here. That is with the medulla. And the reason why is when we have sympathetic activation of this part of the body, we'll have sympathetic nerves being stimulated at the level of the cord, and the cells inside of the adrenal medulla, those are your chromaffin cells, those chromaffin cells themselves are going to act as that postganglionic receptor. All right, that's weird, right? So what that means is the preganglionic neuron is still going to arise from the thoracic portion of the spinal cord, come out as a preganglionic neuron releasing acetylcholine. However, instead of synapsing with a postganglionic neuron, it synapses with a chromaffin cell. Those chromaffin cells inside of the medulla, they still have nicotinic type receptors on them. So acetylcholine binds, stimulates a chromaffin cell, and that chromaffin cell in turn is going to make catecholamines. Catecholamines, remember, are dopamine, epinephrine, and norepinephrine. And these chromaffin cells, they make epinephrine and norepinephrine. So when you are exercising, when you're scared, when you're stressed, and your heart rate continues to be elevated for a little while after, or if you initiate exercise and we want to keep, maintaining a high cardiac output, that is going to be maintained by circulating catecholamines. Those circulating catecholamines come from the adrenal medulla. So they act as what we call modified presynaptic neurons. Kind of interesting, right? Maybe. Right. All right, so that's what a chromaffin cell is. It acts as its own postganglionic neuron. Here's a little chromaffin cell, and it's by a sinusoidal capillary and a medullary vein. So those chromaffin cells themselves, that's what makes the catecholamine. And here we see this pathway illustrated again. We see the preganglionic sympathetic neuron originating in the cord in the thoracic region, coming out, squirting out acetylcholine that would bind to nicotinic type receptors on the chromaffin cell, and the chromaffin cell then taking the place of a typical postganglionic neuron by doing its job of making norepinephrine in response to that. One thing that's a little different, besides the fact that they're not neurons, they're just cells inside of the medulla, 80% of chromaffin cells make epinephrine, whereas 20% make norepinephrine. So whenever you think medulla of the adrenal cortex, or the adrenal glands, don't be sad like this woman. Be happy and think about catecholamines. That's where they come from. When there are too many chromaffin cells, and in this case, it's due to a benign growth. It is the most common pathologic condition of the adrenal medulla. However, in and of itself, it's not a super highly found or something that we see commonly just in general. It's called a Pheochromocytoma. So this is a benign growth of chromaffin cells. Chromaffin cells exist within the adrenal medulla, so that's where you'll find these. And remember, chromaffin cells make epinephrine and norepinephrine. So here in this picture, we see a benign growth of chromaffin cells. So those cells are going to be making tons and tons of catecholamines. So if you have a ton of epinephrine and norepinephrine bumping around the body, you're going to see that blood pressure is going to go really, really, really high. And that's the main symptom of pheochromocytoma, really elevated levels of blood pressure, fairly severe headaches, sweating, anxiety, palpitations, chest pain, fainting upon standing or changing body position, really severe hypertension. You can see levels go up to, they say sometimes the bottom number can be 220, which is really high. So it is extreme levels of hypertension, benign growth of chromaffin cells. All right, so now let's move on to the HPA axis. So what we just mentioned before, that's the medulla, and we would say what stimulates the medulla is the sympathetic nervous system. So when you start exercising or getting into a stressful situation or just get excited, those chromaffin cells are activated by the sympathetic nerves so that you release epinephrine and norepinephrine. We also have the HPA axis, the hypothalamic pituitary adrenal, and that is going to involve the cortex only. So the medulla in and of itself makes catecholamines. The cortex has 3 separate layers. They each make their own product. One of them is cortisol, and that's the one we mainly think of with the HPA axis. All right, so the HPA axis involves steroid hormones. Cells that make steroid hormones make them via alterations to cholesterol. Cholesterol has to come into cells somehow, and it does so through these receptors, LDL receptors, HDL receptors. Cholesterol can enter in these pathways and enter as like free cholesterol. And free cholesterol, when it comes into a cell, it will be modified through an esterification process. And whenever cholesterol undergoes esterification, there's a little bit of a lipid droplet left over, which makes these cells underneath a microscope appear foamy. And usually we would say cells that appear foamy means that there's lipid deposition because they're using cholesterol. However, because of the presentation of foamy cells in atherosclerosis, that just tells us that there's cholesterol there, but generally your vessels don't make anything out of it. They just save it just in case they need it for later. But in that case, it kind of hurts you. In this case, it doesn't. Cholesterol's brought in, undergoes this esterification process. We have some foam cells that are created. However, the main point of this is that the cholesterol that is not just going to hang out as like this foamy little droplet is going to be brought into the cell and then modified into a precursor for cholesterol called pregnenolone. Whenever you see pregnenolone in any kind of biochemical pathway, that means it's going to become cholesterol. We're going to make it into a steroid hormone. So the first steroid hormone we'll talk about is the one we usually think about in the HPA axis, and that is cortisol. So cortisol is, sometimes we call it the stress hormone, but again, it's physiologic stress. Cortisol is released when your body wants to keep you alive. When it senses that there's some time, when you're undergoing a lot of physical stress, maybe you haven't eaten for a while, maybe you're fasting, maybe you've been awake for a really long time, some kind of homeostatic deviation is occurring. So we have the release of cortisol to save you and keep you alive. And cortisol is made inside of cells through this steroidogenic process because it is a steroid hormone, and it is transported through the blood by its own little trafficking protein called transcortin or corticosteroid binding globin. 90% of cortisol is bound to it, and whenever cortisol is around, it lives for about 70 minutes before being metabolized in the body, and it's inactivated by the liver. And that's the major site for steroid inactivation. So when we have something like cortisol, which is a type of glucocorticoid, enter a cell, the way that steroid hormones work is that they're able to traverse right into a cell through their plasma membrane and then go right into their nucleus to mess with transcription and translation so that we can have the creation of new proteins and induce some kind of functional change. Again, cortisol does things to your body to try to save you and keep you alive, but over a long time, not all of the results are necessarily great for you. So generally, cortisol, it helps maintain your blood glucose and keeps your central nervous system working, keeps your heart pumping. It stops your body from losing energy because of an immune or inflammatory response. If you're in a physiologic stressful state, you don't have time to reproduce. You don't have time to undergo intercourse or, I don't know, burn fat in a nice, sleek way. You need your blood glucose to be high. We need to use it right away. We need to liberate all of our stored energy and fat. So it's meant to work on a short-term basis for things like fasting periods or really high stress periods where you don't have access to a lot of things that you would normally. So it's around to try to save you, but it can also be around for long periods of time to not be helpful. So it does things like dampen reproductive behavior by altering HPG activity. It increases breakdown of bone because that's where we store our calcium, and our heart runs on calcium. It inhibits fibroblast proliferation and collagen formation because we don't have energy to make skin really firm and thick and pretty right now. It inhibits ADH secretion so that we have alterations with water retention. It starts to break down the protein in muscles. It makes you really hungry. So it's meant to keep you alive in the short term in case of emergency, but long term, we see things like muscle weakness, ulceration, abnormal reproductive behavior, bone thinning, tissue thinning, skin thinning. So connective tissues start to break down, and we have general unwellness. Also, at the level of the brain, too much cortisol can cause what we call frank psychosis. So when something is frank, it means that it's so clear that you can see it with your naked eye. So when there's a huge amount of cortisol that's being released, initially it is almost euphoric. So people feel this great, surge of energy. It's kind of like a little bit of a mania. So that you feel good under a little bit of stress. It's kind of like when you have a due date or some kind of deadline, you work faster and you feel more productive. But if you feel like that all the time, it's not good for you. So chronic exposure of your body to cortisol, you have a lot of emotional change. You can have depression, frank psychosis again, insomnia, decreased REM, which is when your brain undergoes the most restoration. And when there's a deficiency in cortisol, that's also bad because this is your endocrine system. We want everything to be homeostatic. So you can see depression, being apathetic, which is not caring about things, or feeling irritable, which is your sense of personal space widening. So like most other things, we need to have a set level that is homeostatic, maintained, not too much and not too little. Truly, cortisol release should be reserved for when there's truly something that we need to be saved from. A cool thing pharmacologically about cortisol is that when you put it on your body, it doesn't matter where it is, because it's a steroid hormone, it can enter any cell, and the type of receptor that it binds to is called a glucocorticoid receptor. Guess what kind of cells have glucocorticoid receptors? If you guessed every single one of them, you're correct. So if you put a cortisone-like substance on any single cell in your whole body, it will bind to the glucocorticoid receptor there. There also turns out to be an enzyme present with that called the 11-beta-HSD2 enzyme. And what that enzyme does is take cortisone and turn it into cortisol so that it can do cortisol or cortisol-like things like decrease inflammation and immune responses. So that's why you feel better in the immediate, but if you use a cortisone product for a really long amount of time, any kind of steroid product, you can have those maladaptive effects I mentioned earlier. That also means that you can put it anywhere. So that's a good thing about drugs. You don't have to give it IV or any kind of special preparation. You could put it on your eye or in your mouth or wherever you want. It's going to work because we have those receptors everywhere. All right, this is your HPA axis. So HPA, hypothalamic, pituitary, adrenal. So this is the release pathway associated with eventually cortisol release. The hypothalamus, when there's levels of cortisol that are lower than what we would want homeostatically, releases a product called corticotropin releasing hormone. Corticotropin releasing hormone binds to cells and its receptors on those cells on the anterior pituitary, and in response to that, the anterior pituitary produces ACTH, adrenocorticotropin hormone. ACTH then travels through the bloodstream down to cells in the adrenal cortex, and those cells in response make cortisol. And that cortisol continues to be created through this pathway until levels of cortisol get back to equal, get back to their homeostatic level. When that occurs, we now can send the signal of adequate cortisol back up to the brain to be received by the hypothalamus. When the hypothalamus receives the message that we have enough cortisol, it makes a product called corticotropin release inhibiting hormone, and that acts as an antagonist binding to cells on the anterior pituitary and shutting off production of the rest of this pathway. So we have that axis, which is controlling the release of cortisol going on at all times. So that is the pathway. So here's our hypothalamus, here is the pituitary, here's our adrenal cortex. So when levels of cortisol are altered, we have CRH release by the hypothalamus that travels through the bloodstream down to the anterior pituitary. Those cells make ACTH in response, and then that ACTH binds to cells in the adrenal cortex to stimulate those cells to make cortisol. Once cortisol levels are back to homeostatic set points, that will send our message back up to the hypothalamus that we're good. And instead of carrying forward this pathway, we can make corticotropin release inhibiting hormone. And that is your feedback loop. About cortisol, we do call it the stress hormone. Again, it is not always because of psychologic stress. Anything that is what we consider a physiologic stress increases cortisol release. So really trauma of any type, tissue trauma, infection, injecting something underneath your skin that's bad for you. In this case, a pretty brutal animal study where they were anesthetized. They didn't feel this, but what they're looking at are levels of adrenal hormones, so like cortisol in the adrenal gland itself, and then in the plasma. And at this point where there's an arrow, they broke 2 leg bones of the animal, and we see that levels inside of the adrenal, they go up a little bit, but not until a couple of minutes later. And that's important, generally, physiologically speaking, because in early stress, like in early pain, when we are dealing with shock or pain or anything sudden, that is mediated by catecholamines. It's not mediated by cortisol. Takes a couple of minutes. So you see here about 6 to 8 minutes. That's when cortisol starts to peak after the leg bones were broken. So immediate shock, stress, whatever, is catecholamine mediated, whereas more prolonged stress is cortisol mediated. Another thing, if there's too much cortisol, that is associated with something like Cushing's syndrome or disorder. There's 2 different types. One is going to be plasma cortisol related. The other one is pituitary related. Generally, I'm just tying this up. So when we're talking about cortisol hypersecretion or ACTH hypersecretion, in this case, we are seeing all of the effects of cortisol to the max. So remember, it's there to keep you alive and liberate your glucose and make all of your energy available to you in the case that you're never going to eat again and have to survive a really long time. However, that doesn't mean that you're necessarily going to use it if you're not in a situation where your life is threatened. So we can see fat maldistribution in that your body liberates all this extra fat thinking that you need it for this emergency that's never going to happen, and you don't end up needing all that extra energy. So your body puts it back in weird places like under the chin and in the supraclavicular region or the lower abdomen. We can see tissue thinning. We can see cardiomyopathies, difficulty healing skin, ulcers, or other types of injuries, reproductive issues. But the main thing that we see is this lipid maldistribution is the most frank or easy to see presentation in Cushing. All right, so that was our cortisol. Cortisol is made by the zona fasciculata portion of the cortex. So now let's move on to the zona glomerulosa. The zona glomerulosa makes the mineralocorticoids. There is one main product, and that is aldosterone. If you remember nothing else about aldosterone, remember that it is your sodium-sparing hormone. It is another thing that should only be released when you are in danger of dying. So if you are in danger of dying, in this case, if you hold on to sodium instead of peeing it out, you might know from biochem the saying, where sodium goes, water follows. So when aldosterone's released, it causes you to retain sodium. When you retain sodium, you retain water with it. That means most of your water, which is in like your plasma, we're going to have sodium retained there that will bring water along with it, that will stretch out the vessels by adding to the plasma volume, and that will help maintain blood pressure so that you stay alive. So aldosterone production and release isn't regulated by the HPA axis. Instead, it's regulated by the renin-angiotensin-aldosterone system. So when somebody's dehydrated, when their blood pressure is very low, when sodium levels are low, then we get aldosterone release from the glomerulosa level. If there's an abnormality of that area, you can have too little or too much aldosterone. If you have too much, it's called Conn syndrome. So that is caused generally by an adenoma of aldosterone secreting cells. And if we think about sodium retention and raising blood pressure, if you have a cell proliferating that does that, you'll have very high levels of hypertension, hypokalemia, alkalosis. We also have the opposite of Cushing's disease, which is Addison's disease. So Addison's disease is a lack of adrenal hormones, which includes both cortisol and aldosterone. It can be caused by lots of different things, but it is characterized clinically by low cortisol and aldosterone, but high ACTH. And the high ACTH and low endocrine products tells us that the body is at least trying to correct the issue. We can also see discoloration of melanocytes, because melanocyte stimulating hormone is one of the forgotten things that is a product of the pituitary. So if one endocrine thing ends up getting messed up, usually all of them get messed up in some way. So melanocyte stimulating hormones are a really interesting target with Addison's. All right, final thing to just talk about, even though it's not part of the HPA axis, but it's important to mention, it's from the Zona Reticularis, and it is DHEAS. So this is the main androgen product. So in females, this is the majority of the androgen, and in males, it is definitely taking a second fiddle role to testosterone. But if we look at it, DHEA levels throughout the lifespan, they become pretty high during the fetal period, so as there's differentiation of the tissues, and during the early stages of adrenarche, so the development of secondary sexual characteristics in individuals around the age of 8, that's when we start to see that DHEA gets very high. So it's very important during puberty and then during differentiation in utero. And then it starts to decline throughout the age span, even though it doesn't have a large role in really anything in adults besides maintenance of armpit hair and pubic hair. It is sold as a supplement because it goes down and it's in the androgen family and you can make money off of it. And just to end, that's how people do make money off of it. So if you ever see DHEA in stores, know that you don't necessarily need to buy it. It does go down throughout the age span. Again, in males, the adrenal androgens are relatively negligible in their role next to testosterone. Women, it does make up 50% of circulating androgens, and armpit hair, pubic hair, and libido are thought to be under its control. Again, you can sell it and you can make money off of it. So do with that what you will. And that, my friends, is what we have to say about the HPA axis and then the associated parts of the adrenal glands. But if you can talk through what is made by the hypothalamus, pituitary, and adrenals, I will be extremely happy. All right, everybody, stay smart.